So I think this is my last lecture to you, and then on Friday we have activities that we're going to do. Okay.
Sit in the way.
Opioids. So we've talked about these a couple of different times. Now we're just going to talk a little bit about what you may encounter when you get out into practice. Okay, if you look on page 2 of the handout, I put down your PA prescriptive authority. I have given you this handout several times. We talked about it in writing prescriptions. I've posted it several times when you've done prescriptions. So it's not a new thing. So this is one thing to be familiar with when you go out. I know you'll be writing prescriptions, but you'll also be under the authority of physicians. But knowing what you are allowed to do, don't get caught not knowing, okay? This is something, if you came to me as a student, I would expect you to know at least your rules and laws, okay? So just looking down that second one, looking at 30-day supply for 2 refills for a new diagnosis. This is where a lot of you have trouble when you're writing your prescriptions. If it's a new diagnosis, you can give a fill and then 2 refills. Now, a lot of you want to give a 90-day on that, and I know why you want to do it, but I'm telling you, whenever you start a new drug, I never give 90 days, because if they can't tolerate it or don't want it, then you've got unused drug at home that is liable to cause mischief somewhere, and how people get rid of drugs, they may not always know. So the 30-day fill here is appropriate. They don't like it, they haven't invested that much in it, okay? And then the 2 refills. If you are refilling a chronic disease or a chronic problem, then you can give them a 1-year supply. That's the law. You can write as much as you want, but a pharmacist is under the law to only honor that for 1 year from the day it's written. So if the patient holds on to it, it doesn't do them any good. Okay, it goes from that year. A lot of you get confused on when you're writing the refills is how do you encompass that? So the first fill is the original prescription. So every prescription, regardless of whether it has 0 refills or 20, the first fill is it, that original prescription. The refills are then subsequent to that. So if you are writing for a 30-day supply original, then it's 11 more to get you to a year, okay? Typically we write things on a 30-day supply. Some times you're going to run into places where the insurance is going to want you to write it for 34 or 28, depending on how it comes. So those are variations, and you'll learn those as you go along. The big thing to remember is 30 days. Okay? Sometimes patients are going to run short because that 30 days plays out to, or 360. So they may be over. So insurance will regulate that. You'll figure out the little details as you go along, but know at least those basics. Okay? Questions about that? I'll tell you, you still as a class do not have that down. So tell me where that is confusing you. I'll go over it again on Friday, but why does that, tell me where it trips you up. Yes.
Like one of the prescriptions that I was writing the other day, so it was, I think, an inhaler, and it had like 120 doses, and the patient needed 60 doses per month. I was confused on how to do that. So should I just say dispense one inhaler, and I only give the patient 1 more refill? But so I didn't know how to do that.
Okay, a couple of things. When you most inhalers, except for albuterol, are designed for 30 days. So almost all the steroids are designed for that.
Okay.
Okay. If you're only dosing once a day, you need to back up and ask yourself, why am I doing that once a day? Now, nebulizer is different. Okay. For albuterol, you can always write for 1 inhaler a month, and then put your refills. Some of it doesn't matter what you write, insurance will dictate something. The pharmacy will call you back and say, okay, this is what they're going to do, is that what you intend? Again, those are the more exceptions. Learn the basic rule, okay? All right. Things that don't have clear-cut amounts, like creams and ointments, you're always going to have trouble there. But write it for the maximum of what you think they would use in a month, and then insurance doesn't care. Then they can refill it. If they're refilling it more often, the pharmacy will tell them, I can't refill it until the 20th day or the 21st day. All insurances have rules on when they will allow a refill. Now, a patient could refill it, but they're going to have to pay it out of pocket. Okay? But insurance has their rules. Now, insurance doesn't mean that that is the law of the land. It means that's the insurance rules. Okay? Patients can sometimes do something different. It'll depend on the drug. Again, those are exceptions. Please just learn the basics right now. What else trips you up?
So I'm going to do a refill on like a diabetes medication, and I'm going to see him in 3 months. Is it okay to do dispense 90 instead of giving them 2 additional refills? Because I know with most insurance companies it's cheaper for them to get dispense 90 than to have 2 additional refills.
Your rules say you can do a 90-day supply for an old diagnosis, a chronic ongoing diagnosis. That's what your rules say. Your rules only get you with scheduled drugs and for a new diagnosis. New diagnosis, 30 days, 2 refills is how I interpret your regulations. Your C3s through 5s are 30 days, period, no refills. That's the way I read it. Other questions about refills? These are the things that will get you phone calls. You'll learn quickly because you will get inundated and you'll get tired of it, and it'll increase your workload at the end of the day. Or your nurse will not be able to keep up with you with the amount of phone calls coming in. So just learn them quickly because they'll help you. They'll save your sanity at the end of the day.
We talked about like for a new prescription, whether you give a 30-day with 2 refills or 2 refills is your max. But if it's a new prescription and you're wanting to see the patient back in a month, I remember early in the year we talked about like not giving refills because you want the patient to come back and not just skip their appointment and keep filling their medication. So isn't it at our discretion if it's a new medication to just
Yeah, I
not give
interpret these
refills?
as max. I'll tell you again, and you'll figure it out as you go along, I never use refills as a punitive measure. I don't, because the workload will stack up on you. So what if they can't get there? What if they're caught in traffic, they got to go get their kids, somebody's sick and they can't get there? Then you have a refill now. You now have a phone call from the pharmacy saying, yes.
I was just checking to see if you knew what you were doing.
Did I know what I was doing when I married you? Get out of my classroom.
That's what a racist, that's why you're suspect.
So again, I'll tell you, if you use refills punitively, you will get in trouble across the
Probably
board.
give at least 1, but you don't have to give 2 just because it's a new prescription.
I don't think so. I think these are max. Okay. So you will figure this out as you go along. I never use it punitively. The only time I would do that is when they have missed appointments and you are like, I have to see you again before I will fill this. However, you have got to give them enough to get to that date. Then in the systems you work in, they are going to have rules. They're going to say, if you miss so many appointments, they'll dismiss you from the practice. You don't show up for your appointment so many times, they dismiss you. So almost all big practices will have rules and not regulations, but they'll have rules of their practice. And they'll tell the patients that, and they'll give them warning letters, and they'll document it. So it isn't like you surprise them the first time, but they'll start to warn them. Solo practices, that will be different, because they have a different dynamic there with their community. But in bigger practices, they'll regulate that. Other questions about this? Okay. All right. C2s you can prescribe in an institution. So in the hospital, you will do that. But when the patient goes home, that will have to be done by a physician, your supervising physician. Some of the things I'm going to go over so that you will know, when a patient comes in and they're on a C2, then some things you need to look for. In order for you to prescribe, you must, controlled substances, you must have a DEA registration, and you must register with a state. So in Oklahoma, it's the Oklahoma Bureau of Narcotics and Dangerous Drugs. So just briefly, have they gone over this with you? Okay, so this is just a thing to come. This is how I interpret your rules. So I'm not a PA, I don't have to live under these rules. So I'm telling you what I understand from your regulations. So the DEA is a federal system, okay? It's part of the Department of Justice. It oversees the illegal use of drugs in this country, coming in, going out, within the country. They can take things to court. They can go against you. They can oversee interventions to decrease illicit drug use in this country. So every practitioner has to have a DEA number, okay? I've taught you how to calculate that. So that's your federal. The state, if you're in Oklahoma, then it's with the Oklahoma Bureau of Narcotics and Dangerous Diseases. Okay, if you look on the page 3, there's your DEA number. That is one of the last things that you will apply for. Once you graduate, you'll get certified, registered in a state. Then you apply in the state for your OB-ND if you're here. If you're another state, I'm sure they have those regulations as well. And then your DEA. So you have to have a license to practice. Then you have to have the state's registration and then a federal registration. Okay? They are not cheap. If you look at your DEA number, it will cost you $731 for 3 years. At least they give you 3 years. And then I gave you just the stuff just to kind of give you a warning of here's what's to come. With the Oklahoma, that is a state enforcement. They do the same things. They oversee the use of dangerous drugs, and opioids are considered one of those. And they can take you to court. They can put you in jail. They can regulate how we handle illicit drug trafficking. The cost there is $420, so it's about almost $1,200 for you to just get those ability to prescribe licensed or controlled substances. Okay, questions about those? I'm sure they'll give you information as you get closer to that time. Okay, so let's look at opioids. I'm going to look at non-cancer pain. So they kind of divide pain. If you look in the literature, they're going to look at how do you treat cancer pain, that's one way, and then how do we treat all other kinds of pains, which are referred to as non-cancer pains. Okay. So opioids are your mainstay for your severe pain. They have become under such scrutiny now that they are heavily regulated. You should somewhat consider a blessing you don't have to deal with it, because patients will really drive the desire and the need for, not the need, but their desire for these medications. These drugs work not only centrally, peripherally. So they have central actions that then cause problems from like respiratory depression or sedation. They also have peripheral effects, itching, constipation, those kinds of big side effects. The pure agonist, there's a table on the next, I think not the next page, but a couple of pages in that will list these again. These you should know. These are the most potent pain medications we have, are the pure agonists. They work on the mu receptor. So when they get on the mu receptor, they act just like an endogenous opioid. Questions? Questions? Shelby, anything? Did I miss something? Okay. Pure agonists, morphine, that's the gold standard. Fentanyl, oxycodone, one of the most popular PO, hydromorphone, and oxymorphone. Okay. No, uniformly, there's not one that's better than another. There's some things about each of them that make them desirable in different situations. We're going to talk about those. Lots of individual variation. So people act differently, their perception of pain is different. Pain is whatever a patient tells you it is and whenever they say it's occurring. Okay? So how they respond to a medication also will be different. So we have a variety of medications we can use, and there is no problem in switching from one to another. If a patient doesn't respond to one, then they probably will respond to another in the same class. Lots of availability of different dosage forms, and we'll go through those so that you are familiar with them. If you're an institution, if you're under an insurance plan, they may dictate to you, this is what you have to use, or this is the formulary drug. So some of that will be based on that. One thing to keep in mind is most of these drugs are liver metabolized and renally excreted. So in your elderly, in the people who are going to have most likely have renal insufficiency or liver impairment, these drugs can cause a lot of side effects, adverse effects. Potential for overdose, death due to the respiratory depression for the most part. Okay, page 4, let's look at formulations. There are 3 to keep in mind. There's short-acting, there's long-acting, and there's abuse deterrence. Okay. Short-acting, just like they say, they act very quickly, they don't last very long. We usually use them for acute pain. These are the ones you would be prescribing. Okay. Because in a situation where the patient's been admitted for something that will cause pain, then these are the things you would use. Okay. The long-acting are used much more in chronic pain situations. This is unlikely that you will be prescribing these. You may see people on them in your practice. Cancer pain, this is the way we treat most of that. Breakthrough pain, we use short-acting again. So you may have people who are on very long-acting drugs with short-acting drugs on top of it. Okay? So if we can't maintain the pain through a dosing interval and we have what we call breakthrough pain, then we can use a short-acting. So not uncommon. This is probably one of the few situations I can think of where you will use short-acting and long-acting together. Abuse deterrence. So these drugs they're very potent, very powerful. They are also a very lucrative means of commerce for people. So the ability to take, especially these short-acting drugs, grind them up, solubilize them, and inject them or snort them, very popular. So probably 10 to 12 years ago, they started looking at different formulations that if you tampered with the original formulation and tried to crush it or solubilize it or put it in water, mix it with something, and then use it for another ways of getting it in the body, then the drug would not cooperate. Maybe that's a good way to say it. So there's multiple ways that people have done this, or manufacturers have done this. Whoops. So they're on, oh, did they go off? Do they have a timer? Signal. Okay. Try to power it up again. Okay. So, at break, I'll see if I can find somebody to help me. So what they will do with these dosage forms is that they will embed the active drug in polymers, polymer beads, so that when you add a liquid, it just stays in the polymer and everything they dissolve is inactive material. Or they will add an inactive ingredient that when you add water, it will cause a viscous, it looks like snot or mucus. It gets very thick, so it can't be drawn up, can't be snorted. So that's what these abuse deterrents are. Now, do you need to give everybody an abuse deterrent? No, they're a lot more expensive. Most of them are the long-acting products. There's one short-acting on the market that I'm aware of. So most of them are ones that you wouldn't deal with. But if you assess a situation in which you think that there is a high risk for abuse by that patient or by people that they live with, then that would be a time to look at those abuse deterrents. Situations. Can you think of situations where you might be concerned about abuse?
We've had a previous history.
Previous history, okay, of either illicit drug abuse or other agents for recreational use. What else?
They're having consistent short periods.
Consistent short pill counts are constantly calling in for advancing the refill date. Okay.
Worried about someone in their household who has a history of abuse?
Okay, so people, a history of abuse. I'll tell you, elderly, I have seen elderly at risk. I've seen older people beat up by younger family members to get the medicine to take then to sell. What else?
Seeing multiple clinicians.
Multiple clinicians. So every state now has networks that you can log into to find out a patient's history. If you don't do that, the narcotic agents will show up on your doorstep and will be asking you, why are you doing this? So if they see that if patients are going to multiple providers, they'll alert you. If you are a big prescriber, they'll come to your door. So this will get much tighter for a while, I think, until we find that point where we can adequately and appropriately treat pain. I think pain now is undertreated because people are so afraid of someone coming after them. And rightly so, because the eyes are on the people who have the right to prescribe those drugs. Any questions about the abuse deterrents? Okay. Routes of administration, so lots of ways to get the drug in the body. These drugs, for the most part, are very well absorbed. They have, some of them have high first pass effects. So what is first pass? When a drug what?
Goes through the liver.
Drug goes through the liver and what happens? Liver gets rid of most of it, so the systemic bioavailability is very low. So a low percentage of it gets into the circulation and can be delivered to the site of action. So for that reason, you will find that some drugs, morphine is one of them, has a very high PO dose to IV dose. Okay? So you give 3 to 4 times higher the IV dose than for the PO. Okay, so that's the reason. So those that have high first pass are going to have much higher oral dosing. So keep in mind metabolism, phase one metabolism. If you look back to the very first module, we talked about this. Phase 1 is where the liver takes a drug and it tries to make it more soluble so that the kidneys can get rid of it. So it often conjugates those drugs with like sulfates or glucuronide and puts it together. Drug becomes more soluble, kidneys can get rid of it. What was phase 2 elimination by the liver? We talk about it all the time. I beat you over the head with it. Cytochrome P450 system are phase 2 reactions. Okay, so most of them are metabolized by the liver, so liver impairment, be careful. Renal excretion. Some of these drugs have active metabolites. We'll talk about those as we go through so you'll be aware. And if they can't get rid of those, then the drug hangs around a lot longer, so the side effects become more pronounced. Other routes of administration, patient-controlled analgesia, or PCA pumps, are what they're usually referred to. I put a configuration of one of those to the side in that picture. If you look on the very right-hand side of that picture, usually a drug like morphine or Dilaudid is drawn up in a syringe and is put in a pump. And you, as a practitioner, can say, okay, the patient can have so many milligrams per hour, and they can have it at this interval. So it's programmed into the pump. The patient, if you look at the very bottom of that picture, there's a little handheld device, so the patient can then self-administer that drug within the parameters that you've given. Now, they can hit that little handheld device as often as they want, but if they're dosing too often, it won't give them any drug. Okay? They don't know that, usually. So that is a way that patients can self-administer. These are usually good post-op or in a situation for maybe 24 hours where pain is expected to be at its most severe. It keeps the patient well controlled. The problem when you write PRN orders in a situation where a nurse has to get it, slows down the ability of the patient to get it. There's all kinds of things that the nurse has to do. They have to log it. They have to unlock. If they don't have the keys to the narcotic cabinet, they have to get them from somebody. Depending on the schedule, they may have to have someone else verify that when they get it out. So there's lots of delays in a system when they're trying to get an oral drug to a patient or even injectable drug at patient request. That's the problem with PRN, or as needed or as demanded. So these PCA pumps are often used in about a 24-hour period. It also allows you to see how often are they requesting medicine, because it will give you a printout. You can go on and look. It will show you each hour how much have they received. Sometimes that's helpful in converting them over to an oral agent to see in the next 48 hours or so after an event. Questions about those? Most hospitals will have those. Bigger hospitals will have a pharmacist who that's their job. They do a lot of the management of that pain through those PCA pumps. You have nasal routes, so if you cannot get a drug down a patient through an injectable or through PO, you can use nasal. So fentanyl and butorphanol, which is an opioid antagonist, both have nasal formulations. Then there is the other types of orals. So we have lozenges, we have lollipops, which is, fentanyl has one, buccal films that you put between the cheek and the gum, let it dissolve, sublingual tablets. So lots of ways to get the drug into the patient. I put a picture of prints down there to remind you that fentanyl lollipops are extremely popular. They used to be compounded before they were actually produced by manufacturers, and they are a favorite of people. This one is a picture of Prince with a lollipop. I don't know if it's fentanyl or not, but this is the drug that he overdosed on and died from. This is a picture of one of the manufactured fentanyl lollipops. They are conical instead of round, so they can't be confused. Or maybe not be confused. I pulled this little quote. This is not mine. This was a quote from on one of the Hollywood magazines. At one party recently, I saw them being served to guests on silver platters, and a lot of people were taking them. Frightening, because the drug's very powerful. Okay, questions about those different dosage forms? Okay, so the ones that you would mostly write for is a PCA pump, injectables, and orals. Next page, page 5. These I want you to know, this is part of your objectives. So I want you to know the strong agonist. These are the mu receptor agonists, so morphine, hydromorphone, fentanyl. Don't have to know the brand names. But if you look over across there, they're all C2s. I want you to also know the schedule of the different drugs. The ones in bold are the ones I want you to know. You'll see that they have abuse deterrents that are part of that are related to them. So morphine has one, hydromorphone has one. You also look over in the injection forms, it shows you, if you look down through the list, you'll see most of them come in an injectable form. But with the mild to moderate agonists, they are oral only. So it's easy to remember. So the mild to moderate are the ones you would write for probably most often, oxycodone and hydrocodone. Those are also C2s. You'll see they also have abuse deterrent formulations, oral only. The opioid partial antagonist, or agonist, sorry, buprenorphine, probably one of the more common ones, and butorphanol. C3, C4, so those are ones you can write for. There's some drawbacks to those, but they have their place. If you look over, they have injectables. You'll see buprenorphine has multiple formulations. You look up with fentanyl, it has multiple formulations, probably has the most of any of the opioids. Then there's the mixed mechanism. Tramadol is probably the one that you would use the most. It is not only opioid receptor, but also works on serotonin and norepinephrine reuptake. So when you hear that, what do you think about? Serotonin syndrome. If you use this drug with other serotonin agents, you increase that risk. So it may be one that you get a call from a pharmacist. I've got a big alert that's come up on my screen that says I should not dispense this medication with other ones the patient is using. It's probably that serotonin warning. So keep that one in mind, it's different. There are rectal suppositories as well. You've got morphine and hydromorphone or Dilaudid are the two suppositories that are out there, and then all types of other oral formulations as well. Okay. Questions? So know the schedule, know the type or the class, the strong agonist, the mild to moderate, the partial, and the mixed. Know the drugs that are bolded under those, know their schedules. Here are the abuse deterrents. Just giving you a list of them. I anticipate that they will continue to grow in number. If you look at the very bottom of the list, there is an immediate release oxycodone that is now abuse deterrent. So all of these, for the most part, are going to be long acting. You'll see that for hydrocodone, you've got morphine and oxycodone. Oxycodone is the first one that they came out with, oral agents. So it's been probably 12 or 13 years that it's been out. If you look down through the different technology, a lot of that technology has been patented because it's a special prep or way that they protect the drug from being manipulated. So that's the biggest thing. They are doing something to the drug that will keep it from being manipulated for another reason. Okay, page 6. Let's look at guidelines for using opioids to manage pain. First is to look at multiple modalities. What things can you use together that will decrease the patient's pain, make them more comfortable? So what things can you think of? So what would that include?
Like icing?
Okay, so non-drug things, so icing, eat, rest, whatever. I've given you a list down there. Immobilization, relaxation techniques, that would probably go for more longer term. Using them with non-opioids, so your Tylenol, your non-steroidals, and some of the drugs come in combinations like that. Okay? So we're going to use multiple things so we don't have to rely as much on opioids. Formulation and route, you're going to use a short-acting first. You never go to a long-acting, especially an opioid naive. So somebody who hasn't had an opioid in a long time or never had an opioid, always want to use a short-acting. Using a long-acting can increase the risk of you overdosing them. Drug stays around a long time. So short-acting, onset is quick, offset is also quick, 3 or 4 hours. If they are opioid naive, so you'll see this a lot in the recommendations and in the literature, is they will designate people opioid users or opioid naive. So you want to use the lowest dose possible and titrate slowly. Now slowly is a relative term. If people are having escalating pain or their pain is more frequent than what you're dosing, then you can titrate quickly within like a 24-hour period. But you want to at least see the response the person's having and then adjust accordingly. If you can't use, and you would mostly be using, after the first 24 hours, for most people you'd be using an oral agent. You'll have people that are looking at what you're doing in a hospital situation, and they'll be telling you, if you're using opioid IV too long, they'll be on you. Why can't you move it to oral? So people will be prompting you if you don't change that quickly enough. So you've got rectal administration if you can't use oral. You've got transdermal that you can use, but the transdermal is very long acting and it's very potent, so it probably is not one you will see that much in the hospital. You've got the PCA, bolus dosing, continuous IV infusion dosing, also that can help in the very early time of managing pain. Opioid rotation is a term used to say if one drug isn't working, you move them to another. Okay? So these drugs all have different effects on the mu receptors. There's other types of receptors that are also involved in pain that they may have different effects on. Patient may respond differently. So move them on. You've got other drugs to choose from. Choice of drug. No evidence of one over the other. There are traditions, there are things that people have done for a long period of time, so they're considered more gold standards or go-tos, and that's probably what you will see. Options here, these are the most common ones that are chosen. Oxycodone, hydrocodone, or tramadol from an oral standpoint. I'll say codeine is not used by itself that often. It's usually used in combination with another, like Tylenol or acetaminophen. Here are some things to keep in mind. These will help you. Oxycodone, hydromorphone are available as solo agents. Hydrocodone only comes in combination with Tylenol or ibuprofen. So there's an advantage to that. Because when you're using a combination product, what is going to limit your dosing max?
The Tylenol or the NSAID?
The Tylenol. It's going to be the non-opioid that will limit you. So if you're using a Tylenol-containing product, you're maxed out with the amount that's in there, or that will limit how much opioid you can use. So if you can use a solo agent, in that case, that would help. Here are some situations where it would come in handy. Patient comes into the hospital, they've been on an opioid combination. Okay? In those people, you would most likely then use a solo agent because they've already been on a combination. Or if you're limited in some other way by the Tylenol and concerned about that, then you've got that sole product to use. Be really careful. When people come in, this is where I've seen the most problems, especially with acetaminophen overdoses, and I told you about one of them in the ER, is always ask, always know what kind of opioid they have been on. Most of them will be on a fixed combination, so know if they've been on that Tylenol-containing product. The non-steroidal, we would worry more about elderly renal insufficiency if we're going to use that as well. Don't forget the Tylenol. Okay, next page. In terms of dose, use the lowest effective dose. The ones I've given you are traditionally the places where we start. You can start, and there's pros and cons. You'll see people that will prefer to start with a combination, some prefer to start with a solo agent. There's probably no right or wrong there. You'll get a feel for that as you use those products. Some of them will start off with combination products that's fine. Do you write them for PRN or do you write them on a regular schedule? This is where I see the most suffering induced by a system is when you write a PRN and you've got persistent pain situation. I'm telling you, patients will wait 30 to 45 to an hour to get a pain medicine once they request it. If you're on a busy floor and the nursing staff is stretched thin, you're at shift change, whatever's going on, that patient's going to be delayed. So look at what's the situation and how often are you anticipating that they're going to need pain medication. If you think it's going to be persistent, then put them on a regularly scheduled drug regimen. If not, then put them on demand. If you think it's mild, low expectation of needing an opioid, then an on-demand is fine. If people are in the hospital longer than I'd say 3 days or so, you may be looking at where you would switch them to a longer acting product. I don't think that's going to be the case as often, but it's a potential, is to have him on a long acting. Or you get them in the hospital already on a long acting. Then that's where you may use the breakthrough regimens, where you may have to prescribe something because they're used to one type of pain, something's happened that has changed that pain profile, then they may need different dose or they may need that breakthrough or PRN. Mostly I want you to understand that concept of chronic dosing with short actings on top. Okay, questions? Yes?
So would you suggest then for someone who's like had a surgery on their bones or say, and then going probably for like PCA pumps? Because I know like after my surgery, I really appreciated the morphine PCA pump because whenever I just heard it, I just pushed a button.
Right. Yes.
And it won't let you like overdose.
Right, won't let you overdose. I think those are very good in those first 24 hours. After that, I think that you really should have the expectation patient can move on to a different route. Other questions? Okay, let's talk about the individual products. Morphine, been around forever, gold standard. Considered the pain, the drug of choice for acute severe pain. Comes in lots of different routes. They're listed there for you, IV, PO. It's one of the common drugs we put in a PCA pump. Dilaudid or hydromorphone would be the other one. So these very common. Can be given IM, has a short-acting form, a long-acting form, rectal suppository, lots of different ways to get it into the patient. Thing to remember, significant first pass with morphine. So if you look at the oral to IV dosing, it's 3 to 1. So if you have to convert them to oral, you would use that regimen. The other thing to keep in mind is it has an active metabolite. So you need to know the renal function of patients before you put them on morphine. Because it'll accumulate and they'll get an exaggerated pharmacologic effect. If you go down, you'll see where people do have true allergies to morphine. They're not very common, but they can occur. So the drugs that are alternatives for that would be fentanyl and meperidine. We don't use meperidine very often anymore. It's Demerol because it has lots of side effects. And it's not as safe a drug to use, especially in people who are debilitated. But those are the alternatives. Another thing that morphine does is it causes histamine release. You'll also talk about this in the ADRs. So people can develop a lot of itching. It's not an allergy, it's due to histamine release. And so those, if it's significant enough, there are other drugs that I'll show you as we go through that can be alternatives for that if they are experiencing that. There gives you an idea of opioid naive oral dosing, 15 to 30 milligrams every 4 hours. There gives you a breakthrough. Usually they will look at breakthrough pain with the total dose that the patient's giving and then giving about 10 to 20% of that dose as a breakthrough dose. Placement therapy, first line for acute pain, is very good. Not recommended in patients with renal insufficiency. Questions about morphine? Stories about morphine? Hydromorphone and oxycodone. These are your go-to orals for the most part. Very short half-life, they're very similar to morphine. Oxycodone has about a 1-to-1 potency with morphine, so it's about equal. It is only an oral dose. Has short-acting, long-acting. Its long-acting are usually combined with Tylenol. It does have, well, it's usually Tylenol. This drug is recommended in patients who have renal insufficiency. So this would be a good alternative to morphine, but it's only oral. Placement therapy, good alternative again for renal insufficiency. Also, if patients are experiencing that itching with morphine, this is a good alternative. Okay, hydromorphone, Dilaudid, been around forever, very old drug. It's very, very potent, 7 times the potency of morphine. It's a great go-to drug because its onset's very quick, doesn't last very long, so it's a very good drug. You'll see there that the IV or oral to IV ratio is 5 to 1. This is another one that they like to use in PCA pumps. It has an the active metabolite does not accumulate renal dysfunction, so it's another alternative for your morphine patients or patients who can't take morphine. So again, use it in renal insufficiency, use it in patients who have significant itching due to morphine. Okay, let's break there. Let's take a 10-minute break. We'll come back at 10:30 and pick up there.